futuristic, but I'm going to try and talk about both what we can do right now and what we are going to do in future. And it's going to be divided into dry eye and the gene therapy in delivery in cornea in for future. So at this point of time, if you see the ocular surface inflammation or dry eye, you have multiple drugs which are available in market. And at times you have a lot of patients who are unhappy, have tried multiple cocktail medications, but they're still unhappy. What do you do for them? So let me start with a case example. This is a 55-year-old ophthalmic surgeon from Delhi itself. She has a discomfort, redness, and pain since 18 years. Okay, she has tried technically all medications on available in India and worldwide, but she has no relief. She has no systemic illness. These are her parameters for dry eye. Her OSDI scoring was very, very high. It was around 87. But if you see the other parameters, they are well within agreeable limits. So why was she unhappy with the treatment? We did her confocal nerve analysis and we saw that she had abnormal nerves, reduced nerve density, and dendritic cells were present. They are not the mature dendritic cells, but if you see, the dendritic cells are near the nerves, which cause rise to pain. So let's see, this patient has pain without stain. She has taken all the medications, still she's not responding. If you see the confocal nerves here, she should be responding to one of your anti-inflammatory agents and cyclosporine, but she is still not responding. So what is the missing link here? Okay, this is the case. I'll come back later. So we have published a lot of work in dry eye diseases, corneal dendritic cells, inflammatory mediators, and vitamin D. And what we have found is that this dry eye patients, even though they don't have any known signs or signs, but they are a lot more higher in symptoms. And if you correlate, the vitamin Ds are very, very, very low. That they have a abnormal nerve parameters and high vitamin D. And but multiple parameters and the cytokines which we found abnormal, we do have multiple treatments for them. For example, cyclosporine and tacrolimus for dry eye patients, which targets IL-2. But this patient or many of our patients don't respond to cyclosporine or tacrolimus well when we are giving them. Why? It's a paradox, but if you see here, a lot of these dry eye patients have low levels of IL-2. Now cyclosporine is going to block the IL-2, it is going to reduce the IL-2. IL-2 is an anti-nociceptive factor which is going to prevent pain. So if it is less, and if you pump up with cyclosporine, it is going to reduce more. And the patient is not going to have any anti-nociceptive factors to prevent pain. So a lot of times, these patients, we cannot give cyclosporine, and this is how the chart is, like if it's going to block the IL-2 which the patient needs. Second example, US and other people came in with Zidra, which is the lifitegrast, which targets the ICAM1 and the LFA1, which is also higher, to be found to be higher in dry eye patients. But if you again go back to the published literature and the other work done, a lot of these evaporative dry eye disease patients have lower ICAM1. So if you're going to block this ICAM1, a lower ICAM1, so they don't need Zidra. So what could be the reason? Let's go to third example. This is how the normal cells look like on the epithelial cells on the surface. But if there are any stress like keratoconus or dry eye, the cells start dying and they don't mutate well and they are under stress and they look unhealthy. So we have in past published work on oxidative stress and oxidative stress, which is led by autophagy in keratoconus patients. What we found in that paper was that trehalub and other medications like cyclosporine, they block these pathways and they modulate the autophagy pathway and it reduces the oxidative stress. So we took this further and worked on our dry eye cohort as well, and what we saw was that yes, the trehalose reduces the oxidative stress and it improves the ocular surface health, and this is how the epithelial cells then start growing back and they start breathing again. So there are multiple also. There is autologous, autologous, so if role of autologous serum in ocular surface disease, but it is not for all patients. So we are entering in an era where we need to customize the treatment, because not all the dry eye patients are going to have higher levels or lower levels of IL-2, not all patients are going to have higher levels of ICAM1, and not all patients are going to have oxidative stress. So Here comes the role of future, that we need to customize the dry eye treatment. If the IL-2 levels are higher or the inflammatory markers are higher, then you give cyclosporin or tacrolimus. Similarly, MMP9, you give the ROR gamma inhibitors. If it is other factors, so this is the chart which you will be using in future for a bespoke treatment. Now let's go back to this case. This patient, we did a tear cytokine analysis, and what we found was the IL-2 levels were lower. She was pumping herself with cyclosporin. If you see the fold change ratio, the IL-2 levels are lower. She is pumping it, so it's making them lower again. So it's not going to help. That's why she has ocular surface disorders. ICAM1, yes, it's definitely higher, but at this point of time in India, we are not privileged with lifitegrast, which acts on ICAM1, so we couldn't give her that. But if the third part, if you see here, the nerve growth factors, they were significantly lower, and if you saw, the nerves were also not very healthy. So for this patient, based on that, we gave her a autologous serum. The best part would be to give her an autologous serum. It is also published in literature that yes, on this kind of patients where there is confocal microscopy abnormalities present or allodyna present, if you treat them with autologous serum, they do very well. So we treated her with the same, and this is how her nerves look like. There are improved nerve density, and the dendritic cells have also improved. So after 18 years of life, when we started her on autologous serum, she actually improved, and this is just with 2 years of medication. So this is how you need to customize the treatment. But how do we find that which of these markers are abnormal, which of the markers are higher or lower? What we are doing at Narayan Nethralaya is we are building a point of care diagnostic kit with which you just need to collect tears with a Schirmer strip. Then you need, here in the below video, you need to extract tears. Right now, yes, you need some method to just shake it down, but then you just use a pipette and use it in this cartridge. And once you have it, you just modulate the temperature and put them in the kit, which is looking at this point of time like this, and it will give you the graph on which markers are higher, which cytokines are higher, lower, and how we need to treat them. So this is how the future is going to be. At this point of time, yes, we are working on the kit. It is ready, but it is still at the sensitivity and the specificity stage. We need to see how it goes, and then it will be in the market. So once we have that which marker is lower or higher, we can actually customize the treatment. It can also be used for keratoconic patients, because we are also having a LOX marker in that, because it is known that if the LOX levels are lower, it will affect keratoconus disease, and you need to have some medications or therapeutics to treat them. So what is the future? Shruti has already given a very good talk about the CRISPR editing and the future. We are also right now working on a gene therapy lab, which is the regenerative lab, which have all these therapies. What is future? As again, the LOX levels are lower in keratoconic eyes. So what we have done it right now is in the cells, epithelial cell line, we have taken a control where we have knocked out the LOX from this epithelial cell line, and then once we have this is how loosely the cells are. Once you inject the LOX, these are the different concentrations. You see that the gel, it started contracting, suggesting that yes, when the cells are treated with LOX, it increases the strength of the collagen bed. At this point of time, we are trying with animal studies with our collaborators, but once it is done, you can actually have an eye drop or an intrastromal delivery to pump these patients up with LOX, and actually probably you can stop the patients from undergoing cross-linking. Another thing, corneal scarring or haze. We are also working on a gene therapy modality for corneal scar and haze with SMAD. The early results from animal model, that this is how the controls look like, but if you treat them with a SMAD gene, the haze reduces. So this is what the future is going to be about. Thank you.
Thank you, Dr. Pooja. That was some breakthrough work. I think, and Dr. Soumya will agree with me on this. Both of us being solo private practitioners, we feel the lack of access to such facilities in our own private practice. But I think the Women in Ophthalmology Research branch has now started setting up research labs in different cities, and I think they're trying to implement it at least in Mumbai. And that would help private practitioners like us to contribute to something breakthrough, as well as the implementation of that to everyone.
Yeah, but agreed. So still at that point of time, you have a biorepository, but you need to collaborate with a lab to do all these tests. But it's not feasible for everyone, and your patients are not going to pay for all those elaborate tests. So like you have an inflamma dry eye kit, but it just sees the MMP9. This kit will be probably the future where you can see multiple factors and then customize the treatment. So this you can probably keep it in your clinic and don't need to have a biorepository. Just and few minutes of the test and you can. It's like a glucometer kit. So
waiting for that.
Yeah, soon, maybe this year. Thank you.